So in all kind of cardiovascular diseases, we have seen particularly that atherosclerosis plays a very important role, and that results or that causes decrease in the blood supply, that causes angina, or if it is sudden loosening of this atherosclerotic plaque, then it may cause myocardial infarction, and all these may affect for heart failure and all other aspects. So hyperlipidemia that is found to be one of the major cause. Nowadays it is called as a dyslipidemia. Earlier it was called as a hyperlipidemia. The term is same, syllabus mention hyperlipidemia, but anyone, because since both are synonymous, there should not be any difference. You should be understanding it what it is. So what is this? It is a general term for elevated concentration of lipids in plasma. The lipid level in the plasma, they are increasing, and because of that we call it as a dyslipidemia or hyperlipidemia. We have seen it is a major risk for cardiovascular diseases. There are various kind of lipoproteins and which are varying in size, density and atherogenicity. So they are divided into various classes. One is called as a VLDL, that is very low density lipoproteins. Another are called as intermediate density lipoproteins, that is IDL. The next one are called as a low density lipoproteins, that is LDL. Then next are lipoproteins or apolipoproteins. Then high density lipoproteins, that is HDLs, and triglycerides. So these are various varieties of lipid which are present and which are measurable in nature. Because of that, how it causes atherosclerosis, how it forms layer on the artery, we can see the figure. So because of that, plaques are there, they are formed, and they are liable for rupture. We have seen two types of plaque earlier also during atherosclerosis, this myocardial infarction. We have seen there are two-way type of there. The first one are there, we call it as a vulnerable plaque. The other one are called as a stable plaque. Stable are decreasing the lumen size, and they have little chances of breakup, while the unstable can cause break into that fibrous cap can break because it is very thin, and when the pressure is built into it, that causes break. That way, if you see the difference in both two, vulnerable, that way lumen size is big comparatively than stable plaque, where the lumen size has decreased too much. But despite of that, it is stable one, and it has got little chances or lesser chances of this myocardial infarction, while the unstable, where there are chances, because the fibrous cap is very thin, the layer is very thin, and because of that it can rupture. So these are the biggest problem, and since the lipids which are present in blood, or when their level increases, they are responsible for this. We can say that we should, or it is the biggest risk factor in these atherosclerotic diseases. We can decrease it. So let us see one by one how we are doing it, what are various diagnostic. So next is progressive atherosclerosis leads to coronary artery occlusion, claudification and stroke. These are various, if it whatsoever organ it goes, or wherever it is happening, it will decrease the blood supply to that organ, and therefore it will cause ischemia or hypoxia to that organ, which may result to decrease in the function and damage to the organ. So coronary artery narrowing does not manifest, it is until the end stage of the disease. Those who are interested, there are good lectures are there on YouTube. Those who are interested can go through it. There is one very famous doctor who is arranging all this on particularly about food and all, but again they are very lengthy because they are for layman, so you have to do it fast. That is known as a Saul Heart Clinic. Dr. Vimal Chajet, he is delivering so many lectures on that, so that you can understand some of the basic concept in Hindi. As I told you, it is for layman, and it is for general public to make awareness about various things. But those who are interested can definitely go through it, and if you have any difficulties, you can ask from that. SAOL, Saul heart. I am putting it in. So you can go through it, you can search YouTube for this, and you may find some of the interesting things related to this atherosclerosis and various angina related and myocardial infarction related things for general public, which should be easy to understand. Then this is how the lumen size is affected, and this coronary artery narrowing will particularly will be manifesting when it is there. You will find it interesting that heart can work at rest without any symptoms, even with 30% of supply to it. But when during exercise it increases, then it causes a problem. Hello. So this is how it forms the atherosclerotic plaque with certain time, that is initially very small is there, which is minute and not observable, that is foam cells. Then slowly it develops a slight thickness, we call it as a fatty streak. Then it causes intermediate lesion, then it goes to atheroma, then after that it goes to a fibrous plaque, and then it becomes a complicated lesion which can rupture and that can cause occlusion. Now if we will see the time, it is in the first decade whenever it is initiated. Suppose it is initiated at the age of 30, so first decade it takes around up to fatty streaks around 30 to 40, then 40 to after that it will make these changes, that is intermediate lesion, atheroma, and then later it will form this fibrous plaque and complicated one, which can be dangerous one. And this growth is mainly because of the lipid accumulation. The smooth muscles and collagens are getting deposited into it, and it causes, because of thrombosis, hematoma, these are various things which are coming together, and all are making all are contributing in different ways for that. If you remember earlier I told you, because of this this fatty layer which is there, or fatty streak which is there, because of that endothelial dysfunction is there, that is endothelial will not able to release nitric oxide, which is very good vasodilating and which maintains the elasticity of arteries. Then slowly, because of that elasticity is lost, more friction will be there, therefore it will be injury. This is all part of pathophysiology which will inform, which will give you. There are various basic things which are required, dietary things, sedentary, genetic factors, then present of hypertension, smoking, alcohol. There are so many factors which are contributing. As number of factor increases or number of risk factors increases, the chances of having atherosclerosis is increasing. So whatsoever one can reduce, that can be reduced. So diet control, lipid control, blood pressure control, diabetes control, smoking control. So these are many controls are there, and then one can go for treatment. So these are various factors which are responsible, which can affect or this arterial this one. Now how this thrombosis is happening, we have seen that myocardial infarction is basically occlusion of thrombus is there, which is actually ruptured portion from this atherosclerosis. So from normal is there, then fatty streak we have seen, then fibrous plaque is there, then occlusive atherosclerotic plaque is there, which is almost reducing lumen to half. This is the fourth one, if you will see. And from this fourth one, there are two things. Initially it will be showing the sign at the whenever it is reaching to that much big level. So from fibrous plaque or occlusive atherosclerotic plaque, whenever people will have, there will be angina will be there, and this angina can be there along with increasing age. there will be chances of rupture of the plaque if it is still no attention is paid, and because of that it can cause unstable angina, it can cause myocardial infarction, it can cause coronary death, it can cause stroke, it can cause critical leg ischemia, and almost that much portion of leg has to be removed because severe infection, or we call it as a gangrene, that can occur. So when in whatsoever tissue it goes, if it goes to this heart, then it can be angina, myocardial infarction, or coronary death. If it goes to brain, then it is stroke, or if it is go to leg, so if it goes to liver by chance, then it will be a problem of liver. So these are various places where these problems are there. A majority of acute myocardial infarctions, they are present with the less than 50% of stenosis. So this is what says, that means when even there is a 50, but why this is happening, then we have seen that reason. So even the stenosis is less, or the blockage is less comparatively, people are having a very good life. It is not like angina which is showing symptom. Still people are dying because that plaque ruptures. The biggest problem in this is plaque ruptures, and because of the rupture of the plaque, people they die. So how this plaque ruptures? At the plate where this thickness is there, or where the layer has been formed, so there is triangular structure. If you will see, we will go back. Yes, here. So here, that is the portion which is enlarged. You can see which has been enlarged over here. This is the corner like situation which has been there at the fibrous cap, wherever it is there. This fibrous cap which is there, and the inner one is the lipid core, which is actually atherosclerotic tissues, and the white color is a lumen. This greenish yellow color, or yellowish green color is lipid one, and because of that, this is, you can see this it is a place from which it is separation, you can see, or they are merging together to the cap. And this is the place which is responsible, from where there is a thrombosis is there. So that fissure that ruptures, which is there, and that causes rupture of plaque from that place. So these are the occlusions are there. How this is shared, this is what we call as angiography. We have seen it during that. So there are two images, both are actually separate, and see here it shows a thrombotic occlusion which has not allowing dye to pass, and therefore no color is seen over here, and it is a normal one where each and every artery of that portion is there. Now because it has occluded at such a position, it will cause damage to whole next portion, and as I told you, during myocardial infarction, if the area is very big, then the damage will be very high, and it can rather lead, or it can cause death of the people. So what are the situation, how we are going for assessment, because we know that all these because of the atherosclerosis. So how we are going for various conditions. When we say that there is a arcus sinalis, this is a Latin term, that means white, grey or bluish opaque ring in the corneal margin. Then xanthoma, that is cutaneous manifestation of yellowish cholesterol rich material in the skin layer. So this is how we can see, this is a bluish in the eye. This is a fat like thing layer which is there near cornea. So that is there, that is, we call it as a arcus sinalis. Then xanthoma, these are the fat depositions or fats are there. It may not occur in each and every person, it may be only in few people. Then lipid abnormalities which are associated with the type 2 diabetes, it causes increase in triglyceride, it causes decrease in the HDL cholesterol, it causes increase in the LDL cholesterol. This is all because of the changes that is taking place because of the diabetes mellitus, particularly in type 2 diabetes. Then qualitatively it causes the remnant particles are there, they are accumulated. What are remnant particle? Again you have to go for the metabolism or biochemistry for that. Chylomicron, you might have heard. So on the basis of chylomicron, you can see these are the particles in which lipids are there. and these particles which are carrying these lipids, after carrying the lipid, whatever portion remain, we call them as a remnant particles. So these remnant particles will be accumulated. Then small dense LDL molecules will be there. Then cholesterol enriched VLDL, triglyceride enriched HDL, and there will be increase in the cholesterol ester transfer protein, that is CETP activity. Glycosylated apoproteins and phospholipids, they will be there. So these are two things we can see. Quantitatively means we can measure. Suppose triglyceride level, it will be increased. HDL cholesterol, LDL cholesterol, HDL should be around 40, it will be decreased than 40. That is a quantitative. LDL should be around 100, 120, it will be increased than 120, or if it has become 140, 160, then that is a quantitative. But qualitative means normally it was not present and now it will be appearing. We call it as a qualitative, because remnant particle accumulation, then small dense LDL there, cholesterol enriched VLDL. Earlier it was not there, so it's present. It's just qualitative, means it is there. Otherwise it was not present. Okay. What are the atherogenic dyslipidemias? So LDL cholesterol values are most likely to be made So these are the value likely to be misleading when the patients have metabolic syndrome, that is insulin resistance, NIDDM, that is non-insulin dependent diabetes mellitus, familial combined hyperlipidemia. These are various factors which are there. Simultaneously, few things we shall be trying to understand when we shall have this diabetes mellitus. So what is happening because of that? Because of this NIDDM, that is our type 2 diabetes, or insulin resistance, or familial combined hyperlipidemia. These are, we call them as a metabolic syndrome. And metabolic syndrome is comparatively more difficult, more problematic. So it causes elevated triglycerides. Then there are small dense LDL particles are there. Low HDL 2 cholesterol is there, and these three things causes atherogenic lipid triad, because these three are just like a tripod stand. You might have seen tripod stand in chemistry somewhere, where on which or near gas burners are there. So we call it as a tripod. So they are forming the base for the thing. Similarly, this elevated triglyceride, small dense LDL particles, and decrease in the HDL 2 cholesterol. These three resulting into almost confirmation that it is going towards atherosclerosis. So it is highly diagnostic of insulin receptor resistance. It is crucial to understand that atherosclerosis beginning this particularly developing into this patient which are having this atherogenic lipid trial, and they develop coronary events before their blood sugar starts to rise. So this is the initial one. This is even actual diagnosis of insulin resistance. This thing we shall learn in diabetes. What is insulin resistance? So this is type of this non-insulin dependent diabetes mellitus, which is very serious, very dangerous in that case. And the biggest problem is, we call them all these three things are there. We call it as a silent killers. Diabetes is not identified till means till it has been showing some signs, or there. Or people feel that there is something, and doctor feels that it should be tested. It won't show any sign. By that time it may cause much damage. Same is the case with the lipid level. They cannot be understood, they cannot be recognized until and unless because of one or other reason people go for testing and diagnosis of it. And same is the case of hypertension, also will many times will not remain diagnosed. And these three are dangerous mix of each other. Call it as syndrome X, which is very dangerous: hypertension, diabetes, and hyperlipidemia. So this is almost 100% chance that people will go for atherosclerosis and cardiac diseases. So this is very dangerous, and therefore it has to be taken care of so that the person can save from that. So metabolic syndrome, what it is, what are risk factors? Example of these are These are various risk factors, that is, you can see this, that is the first one is obesity. How obesity is determined, waste circumstances, and men should be having men who are having it greater than 40 inch, or women who are having it greater than 35 inch, they are considered to be obese. Then increase in the triglyceride levels, that is, if it is more than 150 milligram per dl, we call it as a this one. I told you about HDL, that in men it should be always greater than 40, but if it goes less than 40, then we will call it as a decrease in the HDL. And in women it should be always greater than 50 milligram per dl, and if it is decreased from that, then this is a condition. We have seen them as a quantitative measures. Blood pressure should be around 130 by 85, which is a normal. It should be always less than that. If it goes beyond 130 or 85, then it is sort of hypertension, it also contribute. And next is a fasting glucose, it should be always less than 100 milligram per dl. If it goes beyond that, then that is fasting glucose. So these are three more factors are there. So these are all contributing into what we can say metabolic syndrome or syndrome X, as I told you. So what are these things which are contributing in syndrome X or metabolic syndrome? One is blood glucose, that means diabetes. Second is the lipids, that is whether it is hyperlipidemia or normal lipid levels. And third one is what? Blood pressure. So when these three combine together, they have more chances of atherosclerosis, because there are they have their own way, their own mechanisms to do it. So how this is happening? Insulin resistance, atherosclerosis, and various things, how it is there. Insulin resistance can result into hypertension that improves or that increases the chances of atherosclerosis. Insulin causes endothelial dysfunction because of insulin resistance, because because of that water sugar which is present, that causes formation of metabolites which are toxic to the blood. When sugar is increase in the blood, then it causes these metabolites. So this causes endothelial dysfunction. Endothelial dysfunction means decrease in the nitric oxide. Decrease in the nitric oxide means there is a rigidity in arteries, and that is dangerous one. Then hyperinsulinemia, that is also resulting into growth factor like activity, and it causes growth of tissue as it is found in atherosclerosis. Hyperglycemia, that is increase in the blood glucose level, which has got toxic effects, as I told you. Then hypertriglyceridemia, because of this lipid will be sitting over there, it will also contribute to endothelial dysfunction, and it will also cause presence of layer, decrease in the nitric oxide, and entrapment of this lipid into lumen of arteries, resulting into atherosclerosis. Then because of insulin resistance, there will be increase in the small dense LDL, that is contributing. It causes decrease in the LDL cholesterol. HDL cholesterol is found to be better one, or it is helpful to the human being. As HDL increases, it can control LDL and VLDL. So HDL should be increased one, but it will decrease this insulin resistance, and therefore it will contribute to atherosclerosis. Impairment in the fibrinolysis because of the insulin resistance, and it causes hypercoagulability, and because of the more coagulability, thrombus formation increases. So thus insulin resistance is contributing. We shall see again this, or even if I forget, you can preserve this, what are various impacts of insulin resistance, okay, because these are very, very important in diabetes mellitus, that when this happens, because of this insulin resistance, how it is contributing to atherosclerosis, and why that is becoming dangerous. So there are quick, 6 quick steps in reading lipid panel. So when we are going through any report, what we are observing. So look at the triglyceride level. If the triglyceride level is greater than 500 mg per dl, treatment is indicated. and we should go for the drugs which would be helpful in the triglyceride reduction. Now maybe by tomorrow you can go through, because today after this general introduction we will go for treatment. We have already seen while pharmacology which are drugs which are used in triglyceridemia, where the triglyceride level increase. There are certain drugs in anti-hyperlipidemic agents which are having more activity towards triglycerides. So please go through it. Tomorrow you can just as soon as class starts you can just put it on, or today you can put on group. So sort of homework it is there, which are the agents which are helping in the triglyceride level. Then check at the LDL level. If the LDL is more than 190 milligram per DL, drug therapy is indicated regardless of any other finding, even if whatsoever good or bad you find. But if LDL is more than 190, then there should be some treatment which should be given to lower it. So which should be the treatment? What are the drugs which can be causing? If you remember, we have seen how much each drug can cause, how much decrease it can result, how much change, how much decrease it can cause. We have seen it earlier during pharmacology. Please go through this. At lower level, the need for the therapy is based on the patient's overall risk of cardiovascular disease. Therapeutic lifestyle changes are important and they are recommended. They are very useful. Then look at the HDL levels. So in women it should be more than 50, and in male it should be more than 40. If it is less, then it is there. But one thing is very sure, that high HDL does not always mean that there is a decrease in the cardiovascular risk. But yes, if it is more, then it is beneficial, and if it is decreasing than these figures, then the care has to be taken. Calculate the total cholesterol, that is to HDL ratio. How much is total cholesterol? If this ratio is more than 4, then the risk is more. It should be less than 4. That means total cholesterol should be comparatively less and HDL should be more. So if this ratio is like that, then it is always helpful. Then another thing is calculate the non-HDL level. So that is non-HDL total cholesterol minus HDL, because some of the cholesterol is bound to HDL also. So total cholesterol minus HDL cholesterol, that will give you non-HDL cholesterol, or what's your only free cholesterol. If it is more than 130 milligram per DL, or more than 100 mg per DL in the patient with very high risk. Now what do you mean by very high risk? There are two kind of patients. There are patients which are having hypertension, diabetes mellitus, smoking, alcohol. That means their number of factors which are responsible for risk are increasing. So they will go for high risk patient. There are the patients who don't have diabetes, they don't have hypertension, they are not smoking, and thus their risk is less. So if the risk is less, we can tolerate up to 130 milligram, there is no problem. But if the patients are already having other risk factors, then we should have level or our goal at 100 milligram per DL in very high risk patient. Newer data reveal that this calculation is always equal to or better than the LDL at predicting cardiovascular risk. So this data always help in reduction in the cardiovascular. If you try to bring it down, always it is decreasing the cardiovascular risk. Non-HDL is less valuable if triglyceride is more than 500 mg per DL. So non-HDL cholesterol is less valuable because triglycerides are more in that, and therefore non-HDL levels are not very important in that case. Then next is calculate the triglyceride to HDL ratio to estimate the size of LDL. If the ratio is greater than 3.8, that means the small HDL is around 80%, and small LDL always have very high LDL levels. So therefore that is one more indication. So what is our primary goal as per various guidelines? What we have to manage, what we have to do. That is, primary goal will be our LDL-C, and secondary goal will be non-HDL cholesterol. LDL cholesterol and HDL cholesterol shall be one. So what is this? LDL cholesterol is the number one surrogate for apolipoprotein B or ApoB. Apolipoproteins are the transport vehicle that gets cholesterol into vessel wall. So it is a number one surrogate, means LDL-C is converted into apolipoprotein, and then this is causing transfer of cholesterol into vessels, that is blood vessel or arterial wall, and because of that it causes initial streak, or we call it as a fatty streak or fat deposition. So as per this NCAP ATP3 guidelines, if the apolipoprotein B is controlled, it is unlikely that atherogenosis can occur. Means if we can control apolipoprotein B, then atherogenosis can be reduced to very big extent. In patients which are having increase in the triglycerides, that is more than 130 mg per dl, or low HDL which is less than 40 mg per dl, the triglyceride to HDL axis disorders are there. LDL is simply not as good as surrogate for apolipoprotein as not HDL. So that ratio is also very important, and that has to be managed. So this is another goal we have. Non-HDL cholesterol is there. It provides a measure of all cholesterol in atherogenic particles, including LDL, lipoproteinic and triglyceride-rich particles in VLDL. VLDL remnants and intermediate dense lipoproteins. So we can introduce it as a secondary target for therapy in patients with high triglycerides having greater than 200 mg per dl in that guidelines. Then what NCAP3 says about non-HDL goal. So non-HDL triglyceride should be how much? Total cholesterol minus HDL cholesterol, and it should be made goal, that is around 30 milligram. Okay, so it should be around 30 milligram is okay. Non-HDL cholesterol, when triglycerides are elevated, non-HDL is a much better marker for the all important lipoproteins level than it is LDL. So LDL is calculation is done is the total cholesterol minus HDL per VLDL, and VLDL is estimated by labs using a formula triglyceride divided by 5. So these are various ways how this LDL, HDL, VLDL, ideal, that is intermediate density lipoproteins, and all are measured and calculated, and then these all are supporting in various factors. Cholesterol, what are the things? If it is lower, it is important. One, but it is required for many things. Cholesterol is again important for our various hormones, various things, or sort of, these fats are sort of lubricants. So it should not, it cannot be go very less also, it has to be balanced in. So there was a study very famous, or in this particular Framingham, many studies were conducted. One of the very famous studies, Framingham heart study, and it was found that individualized approach based on cardiovascular risk, means each patient should be a separate one, in that on the basis of whatsoever separately signs symptoms are there, accordingly we can plan. First is assess and stratify women into high, intermediate and lower optimal risk categories. So you stratify means we are separating male, females. Then once we are separating what are male, female, age-wise separation, then risk what it is. Again I told you what are the risks. Risk already we have decided. How many risk factors are there? If you have seen just before that we have seen various scores, that is CHA2, D2, VASC2, if you remember. So these are all various scores were there. So like that scores are there, and they measure various risk factors. If you remember, we have seen in arrhythmias and various heart failure conditions that these scores were measured. One was 6-point scale, another one was 9-point scale, and these scales will give you about risk factors. If the risk factors are more, we have seen if it is more than 2, then what we have to do, if you remember earlier presentations. So similarly, these risk factors are there, and how much risk are there we have to check. On the basis of this risk we are going for treatment. The aggressiveness of treatment should be linked with your risk of having heart attack or event in the next 10 years, which is based on the Framingham study. What point score is saying that? It shows that there are points for this, just like CHA, CHAD was 2, CHAD2 was 2 score is there. Points are there for age, total cholesterol, HDL cholesterol, smoking, systolic blood pressure. You add this number, you get 10 years CHD risk in percent category. Suppose one is having age add one, age is more than 40, 1 point or half point, or if it is more than 60, 1 point. Total cholesterol, if it is increased, then 1 point. HDL cholesterol less than 40, 1 point. Smoking, yes. Systolic blood pressure, yes. Then accordingly, as you go, then it indicates that in how many years one will give. So if age is more and other things are okay, then it will take long time. Okay. So this is how chances are there, how many percent are there, accordingly we can go for. This total cholesterol was re-emphasized. It was checked that what is there. Use of Birmingham CAT risk calculators were recommended, and accordingly on that basis scores are there. What are these? Shows what are the categories. Risk categories: high risk person, that is having coronary heart disease, pulmonary atherosclerosis disease, carotid vascular diseases. Carotid means supplying blood to brain. Okay, then cardiovascular dick equivalents, that is diabetes mellitus or 10-year CHD risk ratio if it is more than 20%, and LDL must be less than 100 mg per dl. Optional goal should be made, that is to make it 70 mg per dl in coronary artery disease. Those who are having very high risk, this above are there, which are high risk are there, plus multiple risk factors including diabetes mellitus, tobacco dependence, then severe or poorly controlling risk factors like high blood pressure or recent myocardial infarction or acute coronary syndrome or recurrent coronary artery symptoms and already treatment on this chronic kidney diseases. So there are so many risks are there. So here we should try to keep lipid level less than 70. So see, we have seen 3 levels. In very high risk, we have seen very less risk people, we have seen that it can be 130. Just now, next we are again discussing it. And in other cases where the risk increases, we want to decrease the lipid as much as possible. So here we can try to in very high risk patient, our LDL cholesterol should be less than 70 milligram per dl. Moderate risks, there only 2 or more risk factors are there, or where 10-year risk is less than 10%, then go for 130 mg per dl will be also okay, it can be done. Where there is a high to moderate risk, 2 or more risk factors are there and 10-year risk is greater than 10%, then optional goal is there, that is keep it around 100 milligram per dl. So this is how, on the basis of so many factors, our lipid level can be finalized, that how much it should be there. Those which are very high risk patients, in that what we can do is multiple risk factors, as we have seen diabetes, blood pressure, we have seen all these risk factors. So in that cases, they are very high risk factors. Then severe and poorly controlled risk factors like cigarette smoking, alcohol, etc., and dietary habits. Multiple risk factors are there like high triglycerides, low LDL, and non-HDL-C is more than 130. So these are various factors. Patients with acute coronary syndrome or recurrent angina symptoms, already having kidney disease, chronic kidney disease. So our goal should be in that case, keep it less than 70 mg per dl LDL, and non-HDL cholesterol should be less than 100 mg per dl. Now we shall see about various lipid lowering drug. Already you have seen it in pharmacology. So what are various available lipid lowering drugs? Please go through it again. We have already studied this, and we shall please have a, you can put it on WhatsApp, that what are the drugs and what are their effects. That is, what drugs are better in reduction in the triglycerides, which are better in the improving HDL, increasing HDL, and which drugs are there for decreasing the LDL. So please put it on WhatsApp. This is sort of your assignment. By tomorrow morning, I expect it is there. You just put it on that. So if any difficulty, you can ask. Already we have finished this in pharmacology. and take care, be safe.